And it's really just like fundamentals. But while I was studying for my board exams, I went through this book, and it's a very helpful book. And I guess, Sean, you read through the book, and it's well constructed. And it covers a lot of basic things. But basic things are really good to learn. And you don't need to learn all the articles. You don't need to learn the most recent literature. You need to learn basic physiology and good care of patients, basically. And then the other stuff all changes over the years. And I've been doing this like for a long time. But there's certain things that are constant. So as a beginning, this is just a general introduction. And we're sort of going to talk about, I don't know if Sean gave you gave you anything to read. Have you been derelict in your duties?
No. There's a binder that's available, and all of them are available on PDF form on new innovations, which is secured, and as well as the computers that are located on in the ICU.
And what they are, they're just very easy to read chapters. You would agree?
Definitely.
That give you a good fundamental knowledge of critical care medicine. So the first thing we're going to talk about really is like, what do you do when you evaluate a sick patient, and how do you decide who's sick and who's not sick? Because you guys are students, and you're fourth years?
I'm a
third year. What's third year?
Third.
But within the not too distant future, you will be taking care of people. And you're going to be like the first line of defense, you know, and what you have to figure out over time is going from being a student to being a physician, which people have a lot of difficulty figuring out, and how to evaluate somebody and decide when you need help and when you don't need help, and who's sick and who's not sick. So when you start dealing with people that are critically ill, and we'll just like make this a roundtable discussion, because you have some more senior people here. You know, what are your primary concerns when you're first called to see somebody that you think might be sicker than your normal patient? Anybody?
Airway.
Okay, so you want to worry about their airway. Mental status changes perhaps, but the first thing that I look at when I walk into a room is what's somebody's blood pressure, and are they making urine? And that's what it comes down to. So if somebody's sitting up talking to you, has a blood pressure, and they're making urine, they're probably not that sick. The people that I'm concerned about, like you're saying, so they're hypoperfused, they have a change in mental status, the urinary output is lousy, and they're tachypnic perhaps. And one of the most important indicators for critical illness is tachypnea. And why is that? Why do you think? Like what are the causes of tachypnea?
Primary lung or compensation for underlying metabolic.
Compensation for underlying metabolic acidosis. And most of the people that you see that are critically ill are probably going to be tachypnic and compensating for an underlying acidosis. And when you start thinking about airway, and you start thinking about intubating people, and you start thinking about supporting people from a respiratory standpoint, most often you're going to be supporting people from an acidosis standpoint and not an oxygenation standpoint. And that's because of the underlying metabolic acidosis. And that's the reason ventilators are called ventilators and not oxygenators. But nobody really thinks about that. Why are these machines called ventilators? Because they're really there to normalize pH. So when you first start to look at these people and you see the person that's hypotensive or confused and tachypnic, this is when you start to differentiate about who's sick and who's not sick. And this is when you have to start thinking about what are the next steps in taking care of a patient. And so there's really just some very fundamental things that you have to stick to, and you have to learn to keep things uncomplicated. Because the tendency that we have, especially when we first get into taking care of patients, is to complicate things and to be distracted by many things. And I tend not to be distracted in that way. Now, that happened the minute I walked into the hospital. I'm just kidding. It took a long time to distill things down to a point where I could walk into a room and decide that somebody is sick or not sick within, you know, a matter of minutes, really. Like you guys hang out with me, I just walk into a room and I can figure out what's going on, and I can figure out what the appropriate steps are to take care of patients. And then how do you differentiate, like, who's really sick and who's going to need a lot of support other than this initial physical evaluation where you see, you know, they're hypotensive, they're tachycardic, they're confused, they're not normally the way they are. How do you then decide how you're going to even further risk stratify those patients?
If they're hypotension, responsiveness to fluids, or a variety of lab and endpoint measurements to get a gauge of how sick or how advanced
so that's
it is.
one thing. So you're going to look at how they respond to fluids. You're going to look at their metabolic profile. You're going to look to see if they have a lactic acidosis. You're going to look at these other parameters. And then the other thing you're going to have to learn to do is really pay attention to history. And also look at the patient and stratify them in terms of, you know, age. One of the things you're going to learn, especially if you do ER medicine, and we get a lot of ER people through here, and my goal with ER people is to teach them enough medicine so that I don't react to the patients they take care of in the ER. I'm like, why the hell did they do that? You know, what were they thinking? Younger people will present and they will maintain a blood pressure and they will maintain oxygenation for a much longer time than older people. And you will get fooled by those people. And if you don't act rapidly in younger people, when they decompensate in a big way and they end up dead. Because you've been watching them just hold on because they have reserve. And you can testify to that happening in the emergency room at times. Because you get fooled. Because they can compensate, and then when they finally crash, they have no compensation mechanisms remaining. The other thing you want to look at is, so what is the patient's history when they hit the building? You know, what are the other risk factors? So like if somebody comes in with a pneumonia and it's from the community, who's going to do well and who's not going to do well? So the patients that are not going to do well are the other ones with comorbidities, the patients that are tachypnic, the patients that are hypotensive, the patients that have some degree of renal insufficiency. And so what you really want to do is you want to look at the history. And so are they older patients? Are they diabetic? Do they have a history of cardiac disease? Do they have a history of other comorbidities that are going to factor into their severity of illness index? And so it's very important to look at all that. And I can tell you, having dealt with the house staff here, that a lot of people do not look at the history very well. Because I'll sit there in rounds and I'll go, so what was their creatinine the last time they came in the hospital? I don't know. What was their bacterial flora the last time they came in the hospital? I don't know. And I go, why the hell don't you know? Because what you have at your fingertips now for most of these patients is the ability to go into a computer and look back and see what their prior history was. You have tremendous capacity to do that, and there's no reason not to do that. And why do you want to do that? One, you want to know what their past story is, and number two, if they're coming in with an infection, you want to know whether they've been colonized by resistant organisms, and that's going to change your mode of treatment. So there's all these different factors that you have to think about when patients come into the hospital. And to neglect that is just, to a certain degree, unconscionable. You know, that shouldn't happen. And I can tell you that the people that work with me do that because they know that's what's expected. And that's the way they've been trained to take care of patients. So what are the other things that you need to, you know, think about, you know, when you're taking care of critically ill patients? So let's talk about Airway. You know, so Sean brought up Airway. Who do you intubate? How do you decide to intubate patients? One of the things that you're going to find when you first get onto the floors and you get called to see a patient in distress, or you get called down to the ER and you see a patient in distress, is when are you going to decide to intubate that patient? And when you first do it, and I don't know if you recall this, the first time you make that decision to intubate a patient, it's a very difficult decision to make. And there's a lot of fear involved as to whether or not you're doing the right thing. You know, I don't know what you were like when you first got on the floors, but you get called to see a patient, they're tachypnic, maybe they're hypotensive, and God, should I have this patient intubated, right? And you struggle with that decision-making process. And then what does everybody say? What would your first statement be? Get a blood gas, right? So everybody runs to the floor, they see this patient, they're almost dead, and they turn to somebody and they say, get a blood gas, okay? Because that's what's going to make them decide whether or not to intubate the patient. And not only do they say get a blood gas, they don't even get the blood gas themselves, okay? Which drives me crazy, because I used to draw my own blood gases and draw my own labs and put in my own IVs, and you guys are a bunch of losers, you know, that are not taught to do that anymore. So you're like, oh, well, I ordered the blood gas. And I said, you ordered the effing blood gas? Go draw the effing blood gas and get it to the therapist. But that's not the point. The point is that you have to make clinical decisions. So how do you decide when to intubate a patient? I mean, this is what you're going to be facing like a year from now. Not even a year. And you're going to be facing this 2 years from now, and you're going to go to see a patient, and they're going to say, doctor, they're going to call you doctor, and they're going to go, do you think this patient needs to be intubated? So how are you going to decide to intubate a patient?
If they have like abdominal bleeding.
Well, that would be, yeah, gee, thanks a lot. No, how else are you going to decide to intubate a patient?
So you look at them, right, if they're extremely tachypnic, if they're using accessory muscles, if they look like they're going to get tired.
Okay, so you want to do you actually want to examine the patient. Believe it or not, you have to examine patients, and you have to look at patients, and you have to know what different physical signs are. So what are the impending signs of respiratory failure?
Accessory muscle.
So accessory muscle use, and what are the two patterns of breathing that are consistent with respiratory failure or impending respiratory failure?
Paradoxical chest and abdominal.
Paradoxical breathing, right, and respiratory alternates. So what happens when you take a deep breath in? Like, everybody take one in and figure it out, okay? So take a deep breath in and figure it out.
You
So
generate
your
negative
chest goes out, right, and what does your diaphragm do?
Goes down.
Okay, and your belly goes out, right? So when you have abdominal paradox, your chest will go out and your belly will go in, and that's the diaphragm flopping around. And when you get to the extreme case of that, your chest will go out, then your belly, your chest, and your belly. And you will go into respiratory failure within 24 to 48 hours unless you fix the problem. Now, you have modes of non-invasive ventilation now, too, and that's a whole different topic. And sometimes you can look at non-invasive ventilation, and you know, the COPD patient or the heart failure patient that you know you're going to be able to fix within a short period of time. But the point is, you have to know the clinical findings consistent with impending respiratory failure and not worry about blood gases. You have to worry about the clinical exam of the patient. And I can tell you that patients do much better when they're intubated before they're dead. That's like 100% thing, okay? So those are the types of things that you really have to think about, you know, when you're evaluating patients. There was something else that I really wanted to talk about that just slipped my mind, but I'm sure it'll pop back in. You know, when you are evaluating patients, you know, that's quite important. But it can't be that important because I already forgot about it. But those are the types of things that you really need to think about. You know, when you're dealing with a hypotensive patient, you know, what are the things that you have to think about? So there's a variety of things that cause hypotension, right? You know, Sean already mentioned would sound like a septic patient that's getting resuscitated. And you know, if they remain hypotensive, that after fluid challenges, that certainly changes, you know, the strata of the patient in terms of, you know, their degree of dysfunction. You know, if they're still hypotensive after the addition of pressors, that bumps it up to another level. You know, the other thing that you have to look at when you're evaluating patients as well is, you know, are they going into other signs of organ dysfunction? Okay, so kidneys, like, are really important. I find mine quite useful. And so when you go into renal failure, you know, during a hospitalization or present with renal failure, your mortality is increased by 50% across the board. So there's all these other various indicators that you need to look at. The patient that's got dysrhythmias is another problem patient. The patient that has, you know, liver dysfunction or coagulopathy is another type of patient that you have to be concerned about. So every time you look at a system and you see additional dysfunction, the level of acuity of that patient and their survivability changes to a great degree. There was one point that I wanted to talk about that has escaped me. Hopefully it will return. You can lower that camera. I'm going to sit down. But you know, what are the other things that you you know, need to think about when you're dealing with critically ill patients? You know, one of the things that I think about when patients come into an ICU and when patients come into the hospital, and something that you just need to think about in general is every time a patient comes into the hospital, and you will understand this as you get into clinical medicine, is that what you're dealing with is it's a race against time. And people don't really look at it that way. But hospitals are dangerous places, right? So when I meet with a family or when I evaluate a critically ill patient and talk to either the patient or the family, that's what I tell them. I said, here's the deal. This is a race against time. You have this particular problem, and it's my job to fix that problem and get you the hell out of here before anything else can happen to you. Okay, so when you're dealing with patients in general, and when you're dealing with critically ill patients, the other things that you want to do is pay attention to care that will provide them with a safe environment. Because you don't want to have additional comorbidities that you've created in patients. So what are the things that you have to think about doing in these patients when you're admitting them as general principles of care?
So, aside from basics like airway management and circulation, breath sounds, assessment of neurologic status, and multi-organ dysfunction, you want to, for families, probably provide adequate information and knowledge as well as support.
That's one thing. Educating families is really important. It's really important, and that's a great point. But the other thing you want to do is you want to have in place the right preventative measures for these patients. You know, DVT prophylaxis, GI prophylaxis, attention to detail if you're placing lines. Really get yourself into a way that you do things in a systematic manner. And as you already alluded to, go through things in a systematic manner, you know, from a cardiac standpoint, from a pulmonary standpoint, from a GI standpoint, from a renal standpoint, from an endocrine standpoint, from a hematologic standpoint, from a neurologic standpoint, one after the other. And pay attention to those particular details. And put into effect certain things that will provide you a venue so that you don't create complications in your patients. What we're talking about is like coming to the hospital is a dangerous thing. And so this whole drive that we're undergoing, and you guys are going to undergo to a greater degree than we ever have in terms of looking at things like length of stay and complications you know, is geared with that thought in mind. You know, that you get patients out in an efficient manner and prevent complications. And really, coming into the hospital it's a battle against time. It's like you want to get them out of the hospital before you kill them. And that may seem paradoxical, but it's really true. You know, other principles of, you know, taking care of critically ill patients is really, you know, paying attention to basic physiology and understanding basic physiology and providing things like, you know, adequate resuscitation, adequate nutrition, you know, thoughtful care of a very sick patient. When we get further into details concerning critical care, you're going to see how the application of the basic sciences is so important to the practice of medicine. You know, one of the things that we always talk about in the ICU is the fact that when you're dealing with cardiac medicine, when you're dealing with pulmonary medicine, when you're dealing with ventilators, which are the most common things you'll see in an ICU, you're dealing with physical medicine. And getting an understanding of basic circuitry and basic equations is a really important thing. The other thing that I would tell you guys to do, whether you want to do it or not, is avoid your iPhones, avoid your smartphones, avoid plugging things into formulas. You know, learn formulas. And when you learn formulas, you'll understand the concepts of care that you're providing. I got to tell you, I go on rounds with people. I ask them to figure out a creatinine clearance. They pull out their phone and they start plugging in numbers. And I tell them I'm going to chop off their hands if they ever pull that phone out again, because they need to learn how to take care of patients and need to learn basic principles of care. And you can attest to that fact, right?
Definitely.
He's been threatened by me
Multiple times.
So is Anna, and so is anybody.
I'm missing
You
3
have
fingers.
Yeah. But I only do that out of love and concern, so that you guys learn how to take care of patients. I don't know what else we could talk about, but I mean, these are like the basic concepts when you're going to start to take care of sick people. You know, be thorough in history. Be thorough in, you know, providing basic care. The other thing that you need to learn as a house staff and as students is that when you're taking care of patients, whether they be critically ill or not, we'll just talk about patients in general, and they have a specific problem, and you've decided that you want to consult somebody in the care of your particular patient, is, you know, putting a consult in